genitourinary infections. Intended learning outcomes. To describe the etiology, pathology, clinical manifestations, complications, diagnosis, and treatment for patients with nonspecific infections of genitourinary tract. To describe the pathology, clinical presentation, complications, diagnostic modalities, and treatment for patients with genitourinary TB. To describe the pathology, clinical presentation, complications, diagnosis, and treatment for patients with urinary bilharziosis. Nonspecific genitourinary infections. Definitions. Urinary tract infection, UTI, is an inflammatory response of the urinary tract to microbial invasion. It may be complicated or uncomplicated UTI. Uncomplicated. Microbial invasion. It may be complicated or uncomplicated UTI. Uncomplicated, simple, UTI is one occurring in a patient with a structurally and functionally normal urinary tract. It responds quickly to a short course of antibiotics. Complicated UTI is one occurring in the presence of an underlying anatomical or functional abnormality, e.g. incomplete bladder emptying due to BPH. It takes longer to respond to antibiotic treatment with increased risk of recurrence. Bacteriuria is presence of bacteria in urine, either asymptomatic or symptomatic. Pyuria is the presence of white blood cells, WBCs, in the urine in dipstick or 10 WBC/HPF in sediment of centrifuged urine. Pyuria is mainly caused by bacterial infection. Bacteriuria without pyuria indicates the presence of bacterial colonization of the urine, rather than the presence of active infection. Pyuria without bacteriuria, sterile pyuria, may occur with urinary stones, carcinoma in situ of the bladder and TB infection. Causative organisms. Abacterial. Gram-negative bacilli, E. coli is the commonest pathogen and represents more than 80% of all UTI. Others include Klebsiella and Proteus. Pseudomonas aeruginosa is present in complicated UTI. Gram-positive cocci e.g. streptococci and staphylococci. B. Non-bacterial, they are commonly sexually transmitted e.g. chlamydia trachomatis, ureaplasma urolithicum, and trichomonas vaginalis. Routes of entry. Ascending, it is the commonest route for UTI e.g. renal infection due to routes of entry. Ascending, it is the commonest route for UTI e.g. renal infection due to reflux of infected urine. Other routes include hematogenous, from aseptic focus, lymphatic and direct spread, from neighboring organs. Natural defense mechanisms against UTI include complete periodic emptying of the urinary bladder, antegrade ureteral peristalsis, non-refluxing vesico-ureteral junction and acidic pH of urine. Risk factors for UTI. Urinary tract obstruction, urinary stasis, e.g. by stones, strictures, BPH. Foreign bodies e.g. indwelling catheters, urinary stents, and stones. Vesico-ureteral reflux. Neuropathic bladder. Urinary diversion e.g. ureterosigmoidostomy. Gender, females are more liable as risk factors for UTI. Urinary tract obstruction, urinary stasis, e.g. by stones, strictures, BPH. Foreign bodies e.g. indwelling catheters, urinary stents, and stones. Vesico-ureteral reflux. Neuropathic bladder. Urinary diversion e.g. ureterosigmoidostomy. Gender, females are Vesico-urethral reflux. Neuropathic bladder. Urinary diversion e.g. ureterosigmoidostomy. Gender, females more liable essentially due to short straight urethra. Systemic factors e.g. DM, renal failure, and immunosuppression. Organism factors including its virulence and number. The diagnosis of UTI is based on symptomatology, urinalysis, and urine culture findings. Urine culture is the gold standard for the diagnosis of bacterial UTI. Treatment is usually indicated if greater than 105 colony-forming units/ml in a patient with symptoms of UTI, particularly with associated pyuria. Most cases of simple UTI do not require additional investigations. High-grade fever, recurrent UTI, pregnancy, and systemically ill patients are some indications that require further investigations, e.g. total leukocytic count, leukocytosis, abdominal U/S, KUB film, abdominal CT, post-void residual urine and urodynamic studies. Acute pyelonephritis. It is a clinically diagnosed disease due to acute inflammation and infection process of the pelvic-calyceal system and renal parenchyma. Clinical diagnosis. High-grade fever with acute onset and associated with rigors. Severe flank pain and tenderness. Other symptoms as malaise, vomiting, turbid urine and irritative LUTS. Investigations. Abdominal U/S, it is mostly within normal, but it may show mildly enlarged edematous kidney and renal stones. Urine analysis shows microscopic pyuria and bacteriuria. Urine culture and sensitivity specifies the infecting organism and the appropriate antimicrobial therapy. However, its result takes 3 to 5 days. Complications. Septicemia up to septic shock. Renal or perinephric abscess. Chronic pyelonephritis. Treatment. Drug treatment. Prompt treatment is essential to prevent complications. Antimicrobials, empiric broad-spectrum parenteral antibiotic therapy, e.g. ceftriaxone, is started until the result of culture and sensitivity tests is obtained. Oral antimicrobials are used and continued thereafter. Symptomatic treatment, e.g. antipyretics, analgesics and antiemetics. Intravenous fluids, if there is vomiting or hypotension. Hospitalization is indicated in pregnancy, solitary kidney, and immune-compromised patients. Obstructive pyelonephritis requires ureteric stenting. Chronic pyelonephritis. It is a radiologic and pathologic disease due to chronic corticomedullary inflammation and scarring of the kidney. Diagnosis. The presentation may be asymptomatic, mild renal pain or by complication, S. Abdominal U/S, smaller sized kidney, irregular outline, increased echogenicity and irregular calyceal dilatation with non-dilated pelvis. Urine analysis may show proteinuria, pyuria, and bacteriuria. Complications. 1. Renal hypertension. 2. Renal stones. 3. Renal function loss that may lead to chronic renal failure if bilateral or in a solitary kidney. Treatment. Pathogen-specific antibiotic. Chronic suppressive therapy, long-term use of a low-dose regimen of antimicrobials. Nephrectomy may be carried out for unilateral poorly functioning kidney complicated by hypertension, persistent renal pain or persistent
Pyelonephrosis. It is due to acute infection of a pre-existing hydronephrosis, infected hydronephrosis. It presents by severe renal pain, high-grade fever, rigors, and toxemia. There is renal angle tenderness, and the kidney if palpable is cystic. Abdominal U/S, the kidney is hydronephrotic with internal echoes. Treatment, 4 antibiotics and 4 fluids, followed by urgent insertion of percutaneous nephrostomy, PCN. When the infection is chronic, not promptly treated and with persistent obstruction, the renal tissue is destroyed, leading to loss of renal function. Infection may extend to the perinephric fat and result in perinephric abscess. Ultimately, it may indicate nephrectomy. Renal and perinephric abscess etiology: the organism may come from urinary tract, gram-negative organism, in most cases. Blood, Staphylococcus organism, from a distant site. Clinical picture: fever, high grade, and rigors. Throbbing renal pain and severe renal tenderness with reflex rigidity. Perinephric abscess may be additionally associated with bulging of the renal angle when it extends posteriorly. Reflex muscle spasm leading to scoliosis, concavity toward the affected side, the ipsilateral thigh, psoas spasm. Investigations: abdominal U/S shows the collected pus, its amount and condition of the beneficial to follow up and evaluate the response of medical treatment. KUB may show scoliosis, renal stone, S, and ipsilateral pleural effusion. CT scan is indicated if medical treatment fails. Laboratory investigations include urine analysis, pyuria, bacteriuria, and blood count, leukocytosis. Culture of urine, blood, and drained pus reveals the causative organism and its antimicrobial susceptibility. Treatment: hospitalization. Medical treatment by broad-spectrum 4 antibiotics, 4 fluids together with symptomatic treatment, e.g. antipyretics and analgesics. Follow-up for fever, pain, and abscess size. Drainage is indicated in large abscesses or after failure of medical treatment. Cystitis. Acute bacterial cystitis is due to ascending infection, especially in women, e.g. honeymoon cystitis, and girls. Symptoms: irritative LUTS, frequent voiding of small volumes, dysuria and urgency, and suprapubic pain. Gross hematuria and fever are infrequent. Signs are nonspecific. Urinalysis, pyuria and bacteriuria. Additional imaging, e.g. abdominal U/S, and urine culture are indicated in febrile patients, when symptoms persist or renal pain coexistes. Treatment: unless complicated, trimethoprim sulfamethoxazole or quinolones for 3 to 5 days is sufficient. Cystitis persists in the presence of bladder outlet obstruction, neuropathic bladder, bladder stone, diverticulum or atypical microorganism. Urethritis. It is mainly a sexually transmitted disease in men. Urethritis is either acute or chronic and gonococcal or non-gonococcal. The causative organism is revealed by examination of urethral discharge. If the discharge is scanty, use a urethral swab. The presentation includes urethral pain, dysuria, urethral discharge, and painful ejaculation. Complications: acute urinary retention and acute prostatitis and epididymoorchitis. Chronic, urethral stricture and infertility due to obstruction of the ejaculatory ducts. Treatment considerations: treatment should be started immediately, covering both gonococcal and non-gonococcal types, dual therapy. Sexual partners should be simultaneously treated. Sexual abstinence is highly recommended till cure. Urethral catheterization and instrumentation are contraindicated. Acute urine retention, if occurred, requires insertion of a suprapubic percutaneous cystostomy tube. Acute epididymoorchitis. It is commonly due to infection spreading through the lumen of the vas secondary to urethritis, cystitis, urethral catheterization or instrumentation. It affects the epididymis firstly, then it may progress to the testis. Orchitis may be caused specifically by mumps. Diagnosis: acute severe scrotal pain associated with tender swelling. There may be a history pointing to the source of infection, e.g. urethral discharge and irritative LUTS. Constitutional symptoms, e.g. fever, rigors, malaise, etc. The epididymis and the testis are swollen, tender, and lately appear as one inflamed structure with redness and edema of the overlying skin. It should be differentiated from other causes of acute scrotum, mainly testicular torsion. Complications: abscess formation, recurrence and chronicity, and testicular atrophy, especially with mumps or orchitis, that may risk fertility. Treatment: antibiotics for 2 weeks, e.g. quinolones or ceftriaxone. Bed rest, testicular support, ice packs, anti-inflammatory and analgesic drugs. Any form of urethral instrumentation should be avoided. Fournier gangrene, spontaneous fulminant gangrene of the genitalia. It is a necrotizing fasciitis of the genitalia and perineum leading to necrosis and gangrene of infected tissues. It is unusual for the testes or deeper penile tissues to be involved. This is one of the most dramatic, rapidly progressing and life-threatening infections in medicine. Pathogenesis: it may follow even a trivial accidental or surgical local trauma or urethral instrumentation, especially in diabetics. Both aerobic and anaerobic organisms grow in a synergistic fashion. Diagnosis: it is a clinical one and based on awareness of the condition. There is marked local pain and tenderness in a very ill feverish patient. Crepitation may be present, indicating the presence of subcutaneous gas produced by gas-forming organisms. In a matter of hours, areas of necrosis, blackish discoloration with offensive odor, may develop and spread to involve adjacent tissues, example the lower abdominal wall. Treatment: hospitalize and monitor meticulously the vital signs, risk of septic shock. Without delay, start 4 fluids, take blood for culture and administer oxygen. Parenteral broad-spectrum antibiotics to cover both gram-positive and gram-negative bacteria and both aerobes and anaerobes. A suprapubic catheter is inserted to divert and monitor urine output. Emergent and extensive debridement of necrotic tissue. Later skin coverage of the bare areas is carried out. Fournier gangrene, an early and a late stage. Genitourinary tuberculosis, TB. It is usually secondary to extraurologic primary tuberculous focus, e.g. lungs or GIT. The causative organism is Mycobacterium tuberculosis, an acid-fast bacillus. It is usually caught by inhalation and spreads hematogenously to the urinary tract with a latent period of 7 to 15 years. However, in rare cases, acute diffuse systemic dissemination of tubercle bacilli can result in fatal miliary TB.
Renal tuberculosis. Hematogenous spread causes granuloma formation in the renal cortex, associated with caseous necrosis of the renal papillae. Spillage of this caseous material into the pelvic-calyceal system releases bacilli into the urine and leaves cavitations leading to deformity of the calyces. Rupture of caseous lesions outside the kidney causes perenniferous cold abscess. This is followed by healing, fibrosis and calcification, which causes destruction of renal architecture, UPJ obstruction, and autonephrectomy. Ureteral TB. It is an extension of the disease from the kidney. TB affects all layers of the ureter, which becomes thick-walled, slightly dilated, and non-tortuous, pipe stem ureter. Stricture occurs at UPJ, middle ureter, and sometimes the whole ureter becomes strictured with subsequent hydronephrosis. TB of the urinary bladder. Bladder lesions are secondary to renal tuberculosis starting at the ureteral orifices. The mucosa shows TB ulcers, rare, superficial with irregular outline. Fibrosis around the ureteral orifices may cause vesicoureteral reflux, VUR. When the disease spreads to the muscle, fibrosis results in contracted bladder. Male genital TB. Genital TB is more common than urinary TB. It is common in the 3rd and 4th decades. Hematogenous spread, from a primary focus in the gastrointestinal tract or the lungs, affects the epididymis and the prostate. Subsequently, the epididymis infects the vas deferens and the testis, causing indurated swollen epididymis, thickened beaded vas and secondary vaginal hydrocele. In neglected cases, posterior scrotal epididymal sinus may develop. Likewise, the prostate infects the seminal vesicles. Prostatic nodule/S, hemospermia, ejaculatory duct obstruction and low ejaculate volume are some of the sequels. Complications of genitourinary TB. Secondary bacterial infection. Stone formation. UPJ obstruction or ureteric stricture with subsequent hydronephrosis and pyonephrosis. VUR. Renal hypertension. Renal function loss up to chronic renal failure. Chronic bladder ulceration and hematuria. Contracted bladder. Genital sinus or urinary fistula, spontaneous or after surgical intervention. Male subfertility. Clinical presentation. Symptoms are generally chronic, intermittent, and nonspecific. TB can stand behind any genitourinary symptom. Complications represent the usual form of presentation. Clinically, genitourinary TB should be suspected in the following situations. History of any extraurologic TB, e.g. pulmonary TB. Chronically toxic patient, anorexia, pallor, loss of weight, night sweating. The characteristic thickened beaded vas and posterior scrotal sinus. Genital sinus and urinary fistula after surgical intervention. UTI treatment failure with the current broad-spectrum antibiotics. Sterile pyuria with highly acidic urine. Afebrile renal or perenniferous abscesses. Fever is rare in GU tuberculosis. Investigations. I laboratory. Tuberculin test, it is a good negative test. Ziehl-Neelsen staining of 3 to 5 early morning urine samples to detect acid-fast bacilli. Although it has low sensitivity, it is very specific and good positive test. Culture of urine, semen, or any discharge on Lowenstein-Jensen or Dorset egg media which takes more than 4 weeks. Polymerase chain reaction, PCR, for blood, urine, semen, or sinus discharge. It is highly sensitive, specific and rapid. 2. Radiological. KUB film may show mottled renal calcification, pathognomonic, and calcified bladder. Ultrasonography. Abdominal ultrasonography may reveal cavitary lesions, cortical abscesses, hydronephrosis, or lately cortical scarring. TRUS assess the prostate, seminal vesicles and ejaculatory ducts. IVU or CT with contrast may show Renal cavitary lesions, irregular calyces, moth-eaten kidney, or localized hydrocalicalicosis, due to infundibular stenosis. Hydronephrosis due to UPJ obstruction, ureteric stricture, or VUR. Pipestem ureter. It is a pathognomonic sign. Non-excreting kidney. Contracted bladder is suggestive of extensive bladder TB. 3 cystoscope may show. Hyperemic bladder mucosa with tubercles and ulcers. Gapping, golf hole, ureteral orifice/S. Low bladder capacity, contracted bladder. Biopsy can be taken from bladder lesions. Treatment aims to make the patient non-infectious, preserve the renal function and manage any comorbid condition. Treatment includes medical treatment, antituberculous drugs. Chemotherapy for 4 to 6 months is the mainstay of treatment. It includes a combination of isoniazid, INH, rifampicin, and pyrazinamide. In resistant cases, drug sensitivity testing may be resorted to. Ethambutol. Medical treatment, antituberculous drugs. Chemotherapy for 4 to 6 months is the mainstay of treatment. It includes a combination of isoniazid, INH, rifampicin, and pyrazinamide. In resistant cases, drug sensitivity testing may be resorted to. Ethambutol and streptomycin are 2 other optional drugs. The patient should be clinically and radiologically monitored during treatment and followed up after completion of treatment. Surgical treatment. Primary measures. Antituberculous drugs must be started once the diagnosis is confirmed and should continue for at least 4 to 6 weeks before surgical intervention. Drainage of perinephric collection with concomitant drainage of the kidney, by JJ ureteral stent, may be indicated. Reconstructive surgery for UPJ obstruction, pyeloplasty. Ureteral stricture, endoscopic dilatation and stenting or reimplantation. VUR, ureteric reimplantation with an anti-reflux technique. Contracted bladder, augmentation cystoplasty by an isolated ileal segment. Subfertility, assisted reproductive techniques may be resorted to. See excisional or ablative surgery. Symptomatic non-functioning kidney, nephroureterectomy. Persistent epididymal sinus, epididymectomy. Schistosomiasis of the urinary tract. Urinary schistosomiasis, bilharziosis, is a parasitic infestation caused by the trematode Schistosoma hematobium. The disease has 2 stages, active with actively laying eggs that can cross from veins to the lumen, and inactive when the adult worms die and there is a host reaction to the submucosal entrapped eggs. Ova which pass with urine continue the life cycle of the parasite and leave microscopic abrasions in the mucosal layer causing hematuria. Tissue reaction includes granuloma formation, hypertrophic lesions, fibrosis, atrophic lesions, egg calcification, dystrophic calcification, and metaplasia, precancerous lesions. Bilharziosis of the urinary bladder. The urinary bladder is the most common urinary organ to be involved and heaviest to be affected. Hypertrophic bladder lesions, early foreign body reaction leads to increased vascular supply resulting in nodules, polyps, von Brunn's nests and granulomata. Atrophic bladder lesions, healing by fibrosis hinders the blood supply resulting in ischemic changes that include mucosa, sandy patch. Mucosa, sandy patches, ground glass mucosa, calcific plagues, and chronic bladder ulcer/S. Bladder neck contracture, bladder neck obstruction due to extensive fibrosis at the submucosa and musculosa. Contracted bladder, marked reduction of bladder capacity due to heavy ova deposition that extends to the paravesical fat, with subsequent VUR. Metaplastic lesions, precancerous. Squamous metaplasia, leukoplakia, may progress to squamous cell carcinoma. Glandular metaplasia, cystitis glandularis, may progress to adenocarcinoma. Bilharzisis of the ureter. The lower third is the most commonly affected site. Healing by fibrosis and calcification of submucosal ova leads to ureteric stricture and subsequent hydroureter, dilated and tortuous, and hydronephrosis. Secondary infection and ureteric stone formation may take place. Bilateral affection may eventually produce chronic renal impairment. Other sites of bilharzisis are rare, including the prostate, nodules, seminal vesicles, calcification, and perineal urethra, mass or water cane fistula. Clinical picture includes schistosomal dermatitis, swimmer's itch, is the first clinical sign due to cercarial skin penetration. Acute schistosomiasis, active stage, is concomitant with the onset of ova deposition, producing several manifestations, mainly terminal hematuria, painful micturition, and increased urinary frequency. Other rare manifestations may be diarrhea, abdominal pain, cardiac disturbances, and mental weakness. Chronic schistosomiasis, inactive stage equals stage of complications, can produce irritative LUTS from e.g. bladder ulcer, to reinfection, contracted bladder, or even bladder cancer. Obstructive LUTS from bladder neck contracture, polyps, or cancer. Hematuria, terminal or total, from e.g. ureteric stones, bladder ulcer, or cancer. Post-voiding pain and suprapubic dull aching pain signify constant bladder wall pathology, chronic ulcer or cancer. Renal pain, swelling and or uremic manifestations due to ureteric stricture, stone/S or VUR. Examination may reveal different signs, e.g. renal swelling, suprapubic tenderness, bladder base tenderness or mass, prostatic nodule/S and palpable seminal vesicles. Investigations. Urine analysis, detection of terminally spined ova is diagnostic of active infestation. Microscopic hematuria is usually evident. Serologic tests can aid in the diagnosis of infection, especially in chronic inactive cases where egg excretion is uncommon. Radiological investigations, mainly for the diagnosis of complications. Abdominal ultrasonography for the detection of echogenic bladder growth/S. Hydronephrosis and hydroureter. KUB film can show bilharzial calcifications of the bladder and ureter/S, linear, and the seminal vesicles, honeycomb appearance. Secondary stones, radio-opaque ureteric or bladder stones. Intravenous urography or CT with contrast. Hydronephrosis and hydroureters due to ureteral strictures, ureteral stones, vesico-ureteral reflux or basal bladder cancer. Filling defects in cystogram and hypertrophic or malignant lesions. Contracted bladder. IVU, bilateral dilated tortuous ureters due to bilharzial ureteral strictures. Cystoscopy. Sandy patches and ground glass mucosa have characteristic cystoscopic pictures. Bladder nodules, polyps, granulomata, ulcers, leukoplakia, and bladder cancer may be detected and indicate transurethral resection, TUR, biopsy. Bladder neck obstruction may cause bladder wall trabeculations, diverticula and secondary stones.
Treatment. Medical, oral treatment in the active stage. Praziquantel is the current drug of choice in a single dose of 40 mg per kilogram. It is active against all schistosomal species. Alternatively, Myrazid can be used in a dose of 600 mg daily for 6 days. Endoscopic TUR and biopsy for any bladder growth, ulcers, or leukoplakia. Leukoplakia mandates follow-up as it is a precancerous condition. Bladder neck incision for bladder neck contracture. Endoscopic ureteric dilation for ureteric stricture. Surgical ureteric reimplantation or Bori flap for complicated ureteric stricture. Radical cystectomy for bladder cancer with appropriate urinary diversion. Augmentation cystoplasty for contracted bladder. Obstructive uropathy. Intended learning outcomes. To know the causes and sequelae of hydronephrosis. To describe clinical presentation, diagnostic modalities, and treatment for patients with hydronephrosis. To describe the etiology, pathology, complications, diagnosis, and treatment of bladder outlet obstruction, benign prostatic hyperplasia and urethral stricture. Hydronephrosis. It is dilatation of the pelvicoileal system of the kidney. Causes: upper urinary tract obstruction, renal pelvis obstruction by e.g. renal pelvic stone/S, ureteropelvic junction (UPJ) obstruction, congenital UPJ obstruction, iatrogenic, due to injury of UPJ during renal surgery, ureteral obstruction. Causes in the ureteral lumen, stones are the most common. Causes in the ureteral wall, ureteral stricture. Inflammatory, e.g. bilharzia and tuberculous. Traumatic, e.g. iatrogenic after ureteroscopy or due to trauma during pelvic or abdominal surgeries. Radiotherapy. Neoplastic, primary ureteral tumor or infiltration from bladder, prostate, uterus, or colon malignancies. Causes outside the ureter, extrinsic obstruction e.g. gravid uterus, cervical fibroids, enlarged lymph nodes and retroperitoneal fibrosis. Vesicoureteric reflux, VUR is the abnormal backflow or regurgitation of urine from the bladder into the ureter and up to the kidney. Its causes include primary reflux, due to congenital defective ureterovesical junction that normally acts as a valve. This is commonly present in children, especially in the presence of complete ureteral duplication. Recurrent urinary tract infection is the most common presentation of primary VUR. Secondary reflux, due to increased intravesical pressure in cases of bladder outlet obstruction, neuropathic bladder, and contracted bladder. Hydroureteronephrosis is usually bilateral. Iatrogenic, after EGJJ ureteral stenting or ureteric reimplantation without anti-reflux techniques. Clinical manifestations. Asymptomatic and accidentally discovered hydronephrosis, e.g. during abdominal ultrasound examination for any reason. Renal pain, it is due to stretch of the renal capsule or increased pressure inside the pelvicoileal system. With VUR, renal pain may be experienced during voiding. Renal swelling, it is cystic in consistency with oblong shape, lobulated surface, rounded borders, and free mobility. Gastrointestinal manifestations as pressure symptoms from huge hydronephrosis. Complications of hydronephrosis. Decreased renal function, the presence of obstruction or reflux results in increased pressure inside the pelvic-calyceal system, leading to ischemia and subsequent renal parenchymal atrophy. In advanced bilateral cases, renal failure can occur. Infected hydronephrosis. Secondary stone formation. Increased susceptibility to trauma. Investigations. Laboratory investigations. Urine analysis, pyuria and bacteriuria. Serum creatinine is elevated in advanced bilateral cases. Sonographic appearance of hydronephrosis. Abdominal ultrasonography is the primary imaging modality that may show kidneys, pelvic-calyceal dilatation, renomegaly and decreased cortical thickness. Dilated ureter in cases of ureteric obstruction or VUR. Bladder, post-voiding residual urine and diffuse wall thickening, 2-re VUR. The cause of hydronephrosis, e.g. renal pelvic stone or basal bladder tumor. Imaging for detection of the cause and its level. KUB film to detect radiopaque renal or ureteric stones. Non-contrast MSCT of the urinary tract to detect all types of urinary stones, level and extrinsic causes of ureteric obstruction. CT urography or IVU to detect UPJ obstruction, ureteric stricture and ureteric duplication. It also gives an idea about the function of the kidneys. MRU when the use of contrast material is contraindicated, e.g. pregnancy, impaired renal function and hypersensitivity. Voiding cystourethropy to detect VUR. Retrograde ureterography, intraoperative through a ureteric catheter, and antegrade nephrostography, through an already present PCN, to detect the level of obstruction. Radiological signs of hydronephrosis include concomitant dilatation of the pelvis and calyces. The minor calyces lose their cupping and become flat, clubbed then ballooned. The site of obstruction is identified by the presence of localized narrowing and proximal dilatation of the urinary tract. The ureter below the site of obstruction is normal and may not be visualized. In chronic ureteric obstruction, the ureter becomes dilated, kinked and tortuous. The excreted dye is stagnant and lasts for a long time to be drained. Methods for functional evaluation of the hydronephrotic kidney/S. Cortical thickness, by U/S, of 2 mmS or less mostly means irreversible loss of function of the affected kidney. Contrast secretion, on CT urography or IVU, signifies reversible function. Renal scintigraphy, radioisotope scan is the most accurate method to determine the differential renal function, GFR of each kidney. Diuretic renogram is also utilized to confirm the presence of upper tract obstruction. Percutaneous nephrostomy, PCN daily urine output 200 ml of clear concentrated urine means functioning kidney. Lines of treatment of hydronephrosis. Urgent drainage of urine, using a temporary maneuver to overcome critical situations of urosepsis or uremia. Indications: infected hydronephrosis. Decompensated renal function with bilateral hydronephrosis or hydronephrotic solitary kidney. Methods: PCN or JJ stent in cases of upper tract obstruction. Indwelling urethral catheter in cases of VUR. Treatment of the cause: when the hydronephrotic kidney is still functioning and the patient is not decompensated. Nephrectomy, for unilateral hydronephrosis with irreversibly lost function in the presence of a normal contralateral kidney. Renal replacement therapy. Indication: when the renal function is irreversibly lost and cannot be improved in a decompensated Renal replacement therapy. Indication: when the renal function is irreversibly lost and cannot be improved in a decompensated patient. Methods: dialysis or renal transplantation. Treatment of ureteral stricture. Endoscopic treatment for passable stricture by dilatation or endureterotomy followed by ureteral stenting. Open surgery for non-passable stricture and after failure of endoscopy. Lower third ureter, ureteroneocystostomy, ureteral reimplantation, or Bory's bladder flap. Middle and upper third ureter, resection reanastomosis for short stricture and ileal loop replacement of the ureter for long stricture. Ureterpelvic junction obstruction, pyeloplasty. Treatment of VUR. Conservative measures as frequent bladder voiding and prophylactic low-dose antibiotics in cases without recurrent UTI. Cystoscopic injection of a biocompatible bulking agent to produce ureteral orifice cooptation in cases with primary VUR. Treatment of the cause of 2-re VUR, e.g. bladder outlet obstruction. Ureteroneocystostomy with anterior flux measure in complicated cases. Bladder outlet obstruction. Bladder outlet obstruction, BOO, implies impedance of the passage of bladder urine due to some causes affecting any site of the infravesical passages. Causes of BOO. Prepuce, e.g. phimosis. External urethral medial stenosis, in an orthotopic or a hypospadiac meatus. Urethra, e.g. urethral stricture, stones, or valve. External urethral sphincter, spasm due to painful anal or perianal conditions. Prostate, e.g. BPH, prostatic abscess, or cancer. Bladder neck obstruction, by fibrosis. Others, e.g. prolapsed ureterocele and uterine cervix fibroid or cancer. Pathologic effects of BOO. The bladder exerts more effort and detrusor muscle hypertrophies. The pressure inside the bladder during voiding increases, thus the bladder mucosa is pushed in between the muscle bundles. Later the mucosa outpouches and forms diverticula. Lately, the bladder begins to fail and its contractility decreases, bladder decompensation. Thus the following complications may take place. UTI and bladder stone formation due to urinary stasis. Accumulation of post-voiding residual urine up to chronic urine retention. Overflow urinary incontinence occurs when the pressure inside the bladder exceeds the increased infravesical resistance. Secondary vesicoureteric reflux with subsequent bilateral hydroureteronephrosis and renal function impairment. Symptoms. Obstructive LUTS include hesitancy, intermittency, terminal dribbling, sense of incomplete bladder evacuation and straining during voiding. Acute urine retention is the maximal obstructive presentation. Overflow, paradoxical or false, incontinence. Symptoms of urologic complications, e.g. burning micturition due to infection or stone formation, or symptoms of uremia. Complications due to chronic straining include hernias and piles. Signs. Signs of the cause, e.g. phimosis, narrow external urethral meatus, palpable urethral stone, indurated urethra at the site of stricture and enlarged prostate. Marked suprapubic tenderness in acute urine retention. In chronic retention, the bladder is palpable and shows dullness on suprapubic percussion. Andre, a cystic bladder mass denotes chronic urine retention or bladder diverticulum. Wet meatus is observed with overflow incontinence. Palpable kidneys, signs of uremia, hernias, or piles in neglected cases. Investigations. Abdominal ultrasound for detection of e.g. residual urine, bladder wall thickening, bladder stones, or diverticula and hydronephrosis. Investigations for detection of the cause e.g. KUB, urethral stone, retrograde urethrography, urethral stricture, VCUG, posterior urethral valve, and truss, prostate pathology. Urine analysis, UTI, and serum creatinine, especially in bilateral hydronephrosis. Urodynamic studies. It objectively documents the obstruction and quantifies its degree. It helps in differentiating BU from neuropathic bladder, the main DD. On uroflowmetry, both show low urine flow rate. However, voiding cystometry shows high intravesical voiding pressure with BU and low intravesical voiding pressure with poor bladder contractility. Treatment. Treatment of the cause is the main line, e.g. TURP for BPH. Treatment of complications, e.g. secondary bladder stones. Drainage of the bladder by either urethral catheter or percutaneous cystostomy in. Acute retention of urine. Chronic retention of urine with renal function impairment, unresolving UTI, or overflow incontinence. Benign prostatic hyperplasia, BPH. The prostate gland is composed of glandular epithelial, smooth muscle, and fibrous components. BPH is a histopathological term denoting hyperplasia of one or more of these components. The actual etiology of BPH is uncertain. The prevalence of BPH increases with age. About 50% of men aged 50 years and 80% over the age of 80 years have a histologic evidence of BPH. BPH may be symptomatic or asymptomatic, may or may not cause clinical prostatic enlargement, and may or may not cause BU. Clinical picture. Irritative and/or obstructive LUTS, particularly. Increased urinary frequency at night, nocturia, occurs firstly and later it becomes diurnal as well. Urgency and urge incontinence. Hesitancy, intermittency, weak stream, and straining during voiding. Manifestations of complications including burning micturition occurs secondary to UTI, bladder stones, or diverticulum. Hematuria, it is total profuse hematuria up to clot retention. Acute retention of urine. Overflow incontinence in cases of neglected chronic urinary retention. Uremic manifestations due to reflux and bilateral hydroureteronephrosis. Hernia, mostly inguinal, and secondary piles due to chronic straining. Digital rectal examination, DRE, 4. Evaluation of the tone of the anal sphincter to exclude any associated neurologic disorders. Palpation of the prostate. Normally, the prostate has a flat smooth surface, rubbery consistency, and two lateral lobes with a median furrow in between. In BPH, the surface becomes convex with exaggerated lateral sulci. Rough estimation of the degree of prostatic enlargement. First degree, the examining finger easily reaches the bladder base. Second degree, the examining finger reaches the bladder base with difficulty. Third degree, the examining finger cannot reach the bladder base. There is no correlation between the prostatic size and the presence or severity of symptoms. Median lobe enlargement of the prostate can produce significant symptoms, although mostly not amenable for palpation. Neurological examination is mandatory to exclude any associated neurologic defect that may be primarily responsible for lower urinary tract dysfunction. Differential diagnosis. Neuropathic. There is no correlation between the prostatic size and the presence or severity of symptoms. Median lobe enlargement of the prostate can produce significant symptoms, although mostly not amenable for palpation. Neurological examination is mandatory to exclude any associated neurologic defect that may be primarily responsible for lower urinary tract dysfunction. Differential diagnosis. Neuropathic bladder and other causes of BU. Concomitant prostate or bladder cancer should be excluded. Investigations. Basic investigations. Urine analysis to detect UTI and hematuria. Serum creatinine to exclude renal insufficiency. Serum prostate-specific antigen to exclude prostate cancer. Abdominal U/S for detection of associated bladder pathology, cancer, stone, or diverticulum, PVR and hydroureteronephrosis. KUB film for detection of radio-opaque stones and osteosclerotic prostate cancer metastases. Uroflowmetry may show low flow rate, interrupted curve, or increased voiding time. Transrectal ultrasound, TRUS, and TRUS-guided biopsy if prostate cancer is suspected. Urodynamic studies, if neuropathic bladder is suspected, e.g. cerebrovascular stroke, spinal surgery, and diabetes mellitus. Urethrocystoscopy whenever bladder cancer is suspected, e.g. in cases with hematuria or unexplained burning micturition. Treatment. Watchful waiting, for patients with mild symptoms and no complications. It includes patient reassurance, periodic monitoring, and lifestyle modifications, as decreasing fluid intake before bedtime, moderating caffeine and alcohol, avoidance of exposure to cold, and maintaining a time-voiding schedule. 2. Medical treatment, for patients with bothersome symptoms but uncomplicated. It includes a 1 adrenergic blockers, 5A reductase inhibitors, or combination of both. A 1 adrenergic blockers, 5A reductase inhibitors. Mechanism of action. Block a 1 adrenergic receptors of smooth muscles of the bladder, neck and prostate. Inhibit conversion of testosterone to its active form, dihydrotestosterone. Effect. Reduce the tone of prostatic smooth muscles. Shrinkage of prostatic epithelium leading to reduction of the size of the prostate. Onset of clinical effect. Rapid, hours or days. Delayed, weeks or months. Side effects. Postural hypotension, headache, and retrograde ejaculation. Loss of libido, erectile dysfunction, and low ejaculate volume. Examples: doxycycline, tamsulosin, and silodosin. Finasteride, dutasteride. Surgical treatment, for patients with complications or failed medical treatment. Prior fixation of an indwelling urethral catheter is required to avoid recurrent acute retention till operation, and in cases of gross pyuria, overflow incontinence or renal impairment due to reflux. Transurethral resection of the prostate, TURP. It is the standard treatment. It carries the advantages of being less invasive while resecting and performing hemostasis under vision. In cases of prolonged resection time for a huge prostate, there is a risk of TUR syndrome, hypervolemia and dilutional hyponatremia. Open transvesical prostatectomy, TVP. It has few limited indications, e.g. very huge prostate, concomitant large bladder stone or large bladder diverticulum. It entails enucleation of the hyperplastic part of the prostate, leaving the peripheral zone within the prostatic capsule. Neither TURP nor open prostatectomy eliminates the possibility of future prostate cancer. Other treatment options for the critically ill patient, e.g. laser prostatectomy for patients who cannot stop anticoagulant therapy. Urethral stricture. It is abnormal narrowing or loss of distensibility of the urethra that significantly impedes urine flow. Causes: post-inflammatory, e.g. following gonococcal urethritis. Post-traumatic, e.g. falling astride can result in bulbar urethral stricture. Iatrogenic, after urethral catheterization, instrumentation, or surgery. Diagnosis: history, urethral discharge, trauma, or instrumentation. Obstructive LUTS. Examination sometimes detects induration at the site of stricture. Abdominal U/S may detect significant post-voiding residue. Uroflowmetry. This is a non-invasive test to assess the degree of obstruction and improvement after treatment. It illustrates abnormal voiding pattern and reveals low flow rate. Retrograde urethroplasty is the main diagnostic method to delineate the stricture. Urethroscopy is used for both diagnosis and endoscopic treatment. Differential diagnosis. Other causes of bladder outlet obstruction as BPH. Neuropathic bladder, which may require neurologic and urodynamic assessment. Treatment depends upon many variables and it includes urgent percutaneous cystostomy insertion for temporary urinary diversion in cases complicated with urine retention, renal impairment due to upper tract dilatation, acute epididymoorchitis, paraurethral suppuration or urethral fistula. Visual internal urethrotomy, VIU, for passable short uncomplicated anterior urethral stricture by endoscopic incision of the stricture. Urethroplasty for impassable or complicated strictures and failed VIU. It implies excision of the strict ureter segment and bridging the defect by direct reanastomosis, local skin flap or buccal mucosal graft. Retrograde urethroplasty showing stricture at the bulbar urethra. Urolithiasis. Intended learning outcomes. To describe the etiology, clinical manifestations, complications, diagnosis.